Bağlantı yapabilecek durumda mıyız? İkinci oturumumuzu açıyoruz. CV'yi görebilir miyim lütfen?
Can you hear me?
Dr. Flickinger 1981 yılında Chicago Üniversitesi Tıp Fakültesinden mezun oldu. Radyasyon onkolojisi uzmanlık eğitimini Harvard Tıp Fakültesi'nde tamamladı 1985 yılında. Daha sonra da Pittsburgh Üniversitesi Radyasyon Onkolojisi Anabilim Dalı'nda çalışmaya başladı ve yine o bölümde profesör olarak görev yapıyor. Kendisi işte Lansford'la beraber ilk defa 1987 yılında Amerika'nın ilk gamma knife'ını kurulmasında eşlik etti ve birlikte o zamandan bugüne kadar sürekli beraber çalışıyorlar. İşte burada rakamları gördüğünüz gibi onun da pek çok makale, kitap bölümü, kitap chapter'ı, yazarlığı var. Dr. Flickinger, do you hear me?
Okay, can you hear me?
Hello, how are you?
Sorry, well, very well, Professor Baker. Feeling much better now, thank you.
Thank you very much for accepting our invitation to present your experience to us. So now we are ready here with our neurosurgeon friends, radiation oncologists, radiation technicians, medical physicists, and you are going to present your experience on metastasis and hypofractionated treatments. So the first speech will be on metastasis, and we are all ready to listen to you. Please, Dr. Flickinger.
Well, thank you very much for inviting us to talk and arranging this wonderful conference and helping things and arranging so that things could hook up so that we could speak by satellite or as we. So I want to move on and talk a little bit about treatment of brain metastases, which is the most common indication that we treat with gamma knife right now. And so there are many issues to address in the treatment of brain metastases. So I'd like to touch on that need to be addressed in the management of these patients: whole brain radiation therapy versus radiosurgery alone. And with multiple brain metastases, how many metastases is reasonable to treat? And then we use radiosurgery also for treatment following resection of the tumor resection bed. And so we'll talk a little bit about that. Treatment technique, we'll talk a little bit more about that in the next talk about single versus multiple fractions. Treatment margins, what some groups have used margins around their radiosurgery targets. And there are some issues that have come up recently about the question of are there some advantages to using a high central dose in your treatment? Will that lead to better outcomes? And also there are new issues that have come up with chemotherapy and use of immune modulators along with brain metastases. So radiosurgery, why we use radiosurgery then instead of whole brain radiation therapy is we're looking for better local control of the brain metastases, and there's multiple trials that clearly demonstrate, and retrospective studies that clearly demonstrate better long-term tumor control with radiosurgery, and certainly for solitary metastases, you can show improved survival, improved quality of life. So better quality of life when we avoid the deficits of the cognitive deficits that can be caused by whole brain radiation therapy. And so with radiosensitive tumors, if we give whole brain radiation therapy, we get an advantage of reduced distant intracranial relapse. So it prevents microscopic disease from appearing in the brain, so it's hopefully eradicated at the time of the whole brain radiation therapy. But that doesn't stop tumor cells from continually seeding back into the brain and causing relapse. So for relatively radio-resistant tumors like melanoma, the whole brain radiation isn't very good at eradicating the microscopic disease in the first place, so we don't really see much an advantage for the whole brain radiation therapy. And then when you look at patients with breast cancer where their tumors are relatively sensitive to whole brain radiation therapy, you can clear out the microscopic disease, but these patients, because of controlled systemic disease, will go on to have long-term survival, but their systemic disease isn't completely controlled, so they will continue to seed into the brain and produce new metastases. So trying to clear out microscopic disease in the brain over a short interval when the patient's going to live for years is not very advantageous in the long run. So it's much smarter in those patients that are better prognosis to avoid the whole brain radiation. And the number of trials that show improvements in overall control of the brain often focus on are weighted by our most common indication, which is lung cancer, where the patients have an intermediate survival, and a lot of them will run into problems in 6 months or a year from their systemic disease. And that short 6-month window of reduced intracranial relapse from the whole brain radiation shows up as significant. Whereas with breast cancer, because the time interval is so short compared to the rest of their survival, you don't really see an improvement in distant intracranial control. So our preference is to avoid whole brain radiation, the cognitive deficits that occurs as much as possible. So the absolute cutoff for whole brain radiation is when there's evidence of carcinomatous meningitis, diffuse disease throughout the brain, or the disease is just too great, large metastases and diffuse disease, multiple metastases greater than 3 cm, in a radiosensitive tumor, then treating the whole brain makes sense at that point. So this is our experience we published our experience in multiple indications of brain metastases, and this is just a representative series from patients with non-small cell lung cancer that we've treated with 93% local control in 720 patients. We found that patients who had prior whole brain radiation therapy actually had decreased survival compared to those managed with radiosurgery alone. And of course, this is a retrospective series, and there's some selection factors where the patients getting whole brain radiation are maybe poor prognosis to start with, but the analysis tried to balance that and still found that. And moving on to radiosurgery for treatment of the resection bed, for large metastases, 3 cm or more, patients that that come in and are symptomatic, and they have disease in the range of 3 centimeters, and it's also their symptoms aren't controlled with moderate dose of corticosteroids, then often they're much better managed with surgical resection. And then we want to reduce the risk of local recurrence. Traditionally, that's been with whole brain radiation therapy, which has but that has the problems of cognitive impairment again. So there's been a lot of experience with treating the resection bed of resected brain metastases. And so this is our experience with 120 patients with doing that. And in terms of recurrence, we found that associated mostly with larger volumes and treating with less than 16 gray. So with treating with greater than 16 gray, we've found much better tumor control. Or overall, though, our local control still remains about 86%. But for the larger metastases, the progression-free survival declines down to about 65%. One of the things I found very useful in treating the resection bed of a resected brain metastasis is to, when we're planning the treatment out, is to always bring in the preoperative treatment scan and co-register it, and then I outline draw an outline of the preoperative image or the volume of the tumor, so that can be superimposed on the postoperative image, so we know which areas of the brain are at higher risk, because sometimes the surgical approach will come in a little bit further out, and you may end up targeting areas that are at not very low risk for tumor recurrence, and also, if you're not careful, if you don't pay attention to what was really the tumor was before, you may not appreciate some areas that actually are at high risk and not target that area. So I think that's very helpful. So this is our results with overall in terms of progression-free survival and margin dose greater than 16 gray. We had much better control than with the lower doses. And with the large volumes also went along with large volumes we treated with low doses. So these curves are very similar, low dose and large volume. And this is another approach with these larger tumors that will that could be considered is moving on to is to escalate the dose with a fractionated technique, such as we could do with the icon, so that we'll feel more comfortable. This is in terms of the question of should when you're planning out radiosurgery treatment volume for these post-op cases, should you add a 1 or 2 millimeter margin around the tumor? And a number of authors with the LINAC series have advocated that. This is a LINAC series where they looked at took a different approach. They raised the question of well, there's two questions. Should you do a 2 millimeter margin? And I have another slide for that. Actually, I can skip ahead to. So this is radiosurgery without resection, and there's been some papers on because of the concern, could a brain metastasis infiltrate into the surrounding brain? Should you use a 1 or 2 millimeter margin in the tissue? And this is a nice retrospective series comparing that with LINAC radiosurgery, where they found no improvement in local control with the 2 millimeter margin, but a significant increase in complications. So this is that's a good introduction to this abstract, which is post-op. So there's two concerns. One is in these patients with post-op that right from the start, I did have a concern that when we're choosing between whole brain radiation therapy post-operatively or radiosurgery to the tumor bed, would we start seeing patients who have cerebral spinal fluid seeding, leptomeningeal spread of their tumors caused by the surgery. So the concept of, people have put forward the concept of preoperative radiosurgery to treat the tumor first with radiosurgery and then move on to resect it afterwards. So this is a multi-institutional analysis of a couple centers combining their data, looking at that retrospectively. And for these centers, they treated with no margin for the preoperative radiosurgery, which is clearly the right thing to do based on that last abstract that I showed you, because of no improvement in tumor control. But with a 2 millimeter margin for their postoperative radiosurgery. So they had 66 patients that were treated with preoperative radiosurgery and 114 with postoperative radiosurgery. When they looked at their 2-year rates of leptomeningeal failure, it was 3% in the patients with preoperative radiosurgery right here versus 17%. And then for radiation injury reaction, 5% versus 16%. And the reason for 5% with pre-op, 16% with post-op, and the increase in complications is most likely due to this 2 millimeter margin that they use, that we have not been using. And but the interesting thing is, in terms of overall survival, that this study still could not show a significant improvement in overall survival with the preoperative treatment. But we do have over our other hospital a study for preoperative radiosurgery that's just getting underway. So the other issue I wanted to address was there's been a recent abstract at Astro that raises the question: should you consider giving a higher dose of radiosurgery, a higher dose to the central portion of the tumor? In the early days of radiosurgery, there was a lot of controversy or disagreement between the groups doing gamma knife radiosurgery, which early on almost all of our treatments were designed to treat with 50% isodose, where we would have twice the dose delivered to the center of the target, and the LINAC radiosurgery groups where they would commonly treat to 80–90% isodose, so that the center of the target was only getting 10–20% higher dose. And most things that we've looked at haven't seen that much of a difference. But the issue of what happens with tumor hypoxia could be a problem there, and what that the high dose in the center might address. So very often in treating brain metastases, we will see lack of central contrast inside a brain metastasis, and that is from the tumor outgrowing its blood supply. So from radiobiology, we know that it takes about 3 times the dose of radiation to kill fully or hypoxic cells that do not have very much oxygen, but that are still viable, compared to cells that are fully oxygenated next to the capillaries. And the idea of a high central dose is, if you actually get the high dose in the region that's hypoxic, you might get better tumor control. So we found in looking at our brain metastases very early on, both at Pittsburgh and at University of California, San Francisco, that if we looked at tumors with heterogeneous enhancement patterns as opposed to those that light up with bright contrast enhancement throughout the tumors, that we have much poorer tumor control even when you control for size of tumor, histology, and dose delivered. So that and that lack of central contrast enhancement correlates with areas of hypoxia in many tumors. It's very easy to measure in head and neck tumors and cervical cancers, where you can stick an Eppendorf electrode and measure oxygen tensions in tumors that are similar, that show heterogeneous enhancement, and show that those are areas of hypoxia. So the ways we can address that in treatment planning are that problem are through fractionation, doing multiple fractions, as we'll get to into the next talk. We can also plan out a radiation dose to deliver a higher dose in the center. So when we're treating a solitary brain metastasis like this, I very often add several other centers and treat to a higher isodose, sometimes switch to the 40% isodose, so we can target the non-enhancing portion with a dose of 25 gray or 30 gray. And so here's one where I didn't make any special effort. I just treated at the 40% isodose because it's all scattered, and we were able to deliver a much higher dose to that area. So this was the abstract that was in Astro, where they looked at tumor control and found, according to central dose, and found for non-small cell lung cancer that they found improvement in local control when more than 24% of the metastasis would receive 30 gray or more. So it wasn't, at least in this study, they didn't try to correlate that with outlining the central portion of the tumor that's not enhancing, as I did with this plan. I actually outlined that and added more shots and checked the dose. But that's the rationale for why this might work and improve our local control. So it's something to think about in your treatment planning of brain metastases. So the other things that are other issues that are interest that have come up in the management of brain metastases, it comes from our medical oncology colleagues, and then the use of different biological agents and chemotherapy drugs. So there were a number of reports that have made radiation oncologists nervous when benmurafenib was introduced in the management of metastatic melanoma. So there were case reports showing severe skin toxicity. Here's somebody treated to the spine with a simple APPA field pattern, where you see this injury of the liver occurring from the radiation treatment field. And this occurs very commonly. It's with the BRAF inhibitors. It's particularly associated with benmurafenib, but not as much as with the other BRAF inhibitors. So benmurafenib is more potent radiosensitizer than the other inhibitors. And I also had seen a case report of somebody reporting radiation injury reaction from radiosurgery, which speculated the same thing, but it was a simple case report. But fortunately, there had been a larger series published, and this series kind of settled the matter for radiosurgery, which is what we would have thought, that it should be safe the way that we do radiosurgery with a highly conformal dose and sharp dose fall-off, that we're not going to see much of a difference. And this is a series with 80 patients treated with benmurafenib. So even though it may improve your local control, because our dose treatment planning has such a sharp dose fall-off, there's no appreciable increase in complications with radiosurgery. And then another thing that's come into medical oncology that's caused a lot of excitement and enthusiasm in both medical oncology and radiation oncology are the new immunomodulator drugs like Opdivo, and so the anti-PD-1 checkpoint inhibitors. So with those, what we're seeing, they're based on the principle that chronic T-cell activation with PD-1 is induced on T cells, and engaging PDL1 on macrophages and tumor cells to mediate an immune escape via T-cell exhaustion. So you can block this interaction that's exhausting the T cells and preventing a proper immune response with the checkpoint inhibitors, nivolumab and pembro, and with the hope that the hope and also the demonstrated effect that you can have immune response and better cell killing. So there, in radiation oncology, we have this principle of abscopal effects that's been demonstrated in very laboratory models, where if you treat multiple tumors, if an animal or a patient has multiple metastases and you treat one of them, you can see an effect on the other metastases that are untreated, sometimes from an immune response. So if you've augmented the immune response with drugs like this, hopefully you will see both in metastatic disease, but in other remote from the site, but also in tumors like glioblastoma, where we're treating the enhancing portion of the tumor, but we know that there's tumor cells infiltrated farther away from the radiosurgery target. So we hope that to get more of a response, and certainly with brain metastases, we're hoping to. There's microscopic disease in the brain elsewhere that we're hoping to, and the rest of the body, that perhaps we can augment the immune response with radiosurgery. And the advantage of combining radiosurgery with checkpoint inhibitors too is that you don't have the problem that you have with conventional radiotherapy, where when you're using a margin around the brain, anything that you treat, a 1 centimeter margin, you're inhibiting all the immune cells in that surrounding border that could be there to help fight the tumor and help kill it after you've injured it with the radiation. So with highly conformal radiation treatments like radiosurgery, actually that's the only highly conformal type of radiation treatment is radiosurgery. That we are, I guess, brachytherapy. You could put needles and radiation seeds in something. But with something with highly conformal like that, we're not inhibiting the immune response in the surrounding tissue as much as with regular radiotherapy. So there are early series of that with very nice tumor control with nivolumab. And this series points out with the resected tumors, particularly in the post-operative setting, that they were seeing very good tumor control with that. And then the other thing that gives us hope in the management of brain metastases is just chemotherapy drugs that cross the blood-brain barrier and are targeted to gene arrangements in particular tumors. And so we do see agents like that, where we're seeing responses of untreated brain metastases, 43% complete response with no prior radiation. So with alectinib. So hopefully there are more drugs coming on the scene that will help with management of distant disease in the brain, particularly where we don't have to, where we can keep staying away from whole brain radiation therapy. So hopefully I've addressed a lot of these issues and things that interest to you. So whole brain radiation, we try to avoid that as much as possible. Tumor bed resection we've talked about, and we'll talk about, next talk's a little bit more about using multiple fractions. It's not clear we need to treat any with any treatment margins, and we need to perform studies to see whether the high dose high-dose treatments in the center, treating to 40-50% isodose versus 80% isodose, will lead to an advantage, particularly if we pay attention to non-enhancing central portion of the tumor. And then we have greater hope with improved chemotherapy and immunomodulation. Okay, well, thank you very much.
Thank you very much, Dr. Flickinger. It was an excellent review of this very important subject. So if there is any question or comment to Dr. Flickinger's speech, please. Yes, Dr. Kadir Tufan is a neurosurgeon working with gamma knife radiosurgery. He wants to ask.
Flickinger'la tekrar burada birlikte olmak gerçekten mutluluk verici. Belki önce bir önerim olacak. Gamma knife öğrenimine başlarken, daha elinizde gamma knife yok iken Amerika'ya gidiyorsunuz. Değerli hocalarla birlikte çalışıyorsunuz. Başlangıcı öğreniyorsunuz ama esas problemleri kullanmaya başladığınızda yaşamaya başlıyorsunuz. Ve o zaman karşınıza çıkacak problemleri sormayı çok istiyorsunuz. Belki bir kez daha öğrenimden 1 yıl, 2 yıl sonra bir kez daha bu hocaların yanına gidip tekrar çalışma fırsatı bulmak çok bence faydalı olabilir. Metastazlarla ilgili şöyle bir problem yaşıyorum. Şimdi beyin metastazları dediğimizde aslında bir kutuya bir dolu farklı tümör tiplerini koyuyoruz. Bunların tedaviye yanıtı aynı değil maalesef. Hem organdan organa değişiyor. Mesela bir meme metastazıyla akciğer metastazını aynı metastazmış gibi aynı dozlarda tedavi ediyoruz. Artı bunların bir de alt tipleri var. Alt tiplerinin de şeyi tamamen farklı. Cevabı tamamen farklı. Mesela meme kanserlerinde daha fazla problem yaşıyoruz. Acaba bunun çözümü biraz önceki anlatılan konuda olduğu gibi farklı ilaç tipleriyle bu tümörleri sentez edip ondan sonra tedavi etmek mi olacak gelecekte? Yoksa acaba yeni bir doz planlaması mı yapmak durumundayız? Yani farklı tümör tiplerine farklı dozlar mı vereceğiz acaba gelecekte? Bu konuda Flickinger'ın fikrini çok merak ediyorum.
Yes, I think that's a very good point. That's why when we've looked at our outcomes with brain metastases, we've tried to analyze each of the different types of tumors differently. I think the one thing we know that unites them, that makes them, that's similar between the different metastases is that the response of the vasculature to the high-dose radiation, that's high-dose single fraction or high-dose limited number of fractions, it produces a lot of the response is from the normal tissue vasculature. So that's where a lot of the similarities are, but in terms of staying ahead of the tumor and reducing the failure rates, those are the outliers of the patients, the 20% or so, that 15-20% that we don't control, and that may vary quite a bit from one histology to the other. So I think will continue to be very important to look at these individually and try different agents, and a lot of the studies do, and particularly with targeted drugs, are not only looking at individual types of cells like lung cancer versus breast cancer, but the different types of lung cancers and breast cancers with different gene rearrangements. So that's, I think, what we'll see in the future is treatment that's tailored not only to different histologies of brain metastases, but different brain metastases from tumors with different genetic mutations.
Thank you very much. And another question we have, please.
Ben Türkçe bir katkı, bir merak ettiğim şey sormak istiyorum. Her dokunun natürel bir rezonansı var. A ve B maddelerinden yapılmış dokuların tabii rezonansı A ve B matematiksel formundadır. Eğer siz A'ya uygun bir natürel rezonansla dalga gönderirseniz A'yı parçalayabilirsiniz ama B'ye hiçbir şey olmuyor. Şimdi tümörlerin EEG dalgaları da birbirinden farklı. Acaba biz gamma knife radyosörcülü cihazlarının dalga formunu tedavi etmek istediğimiz tümör dokusunun natürel rezonansıyla uygun hale getirirsek ki nöron kültürlerinde nöronların ürettiği dalgalara senkron dalga verdiğimizde apoptozis görülmüştü.
Vakit kısıtlılığımız
Acaba tümörde de bunu uygulayabilir miyiz? Özet budur. Yani tümörün dalga normunu elde edip o dalgaya senkron dalga göndermemiz gerekir diye düşünüyorum.
Thank you. Do you have an answer for this question? Because it's an almost scientific but a philosophic question also.
I don't really have an easy answer for that or comment. It certainly seems like an interesting concept that bears some exploration.
Okay. Thank you very much. Is there any other question? Okay, there is no other question for this topic. Now we have to move to second topic, which is single fraction to hypofraction. Hypofractionation is very popular nowadays, and a lot of patients can be treated with hypofractionation also. So now we would like to learn what is your opinion and what is your experience with hypofractionation. Thank you.
Okay, thank you. So for this, despite the availability of different techniques to hypofractionate radiosurgery, the comparisons and the choice between single fraction and hypofractionation, the data and studies that really answer this question are relatively poor quality, so most of my talk will be just opinion. We don't have large randomized controls trials of treating things that could be treated with single versus 3, 5 brain sessions of radiosurgery. And in the Gamma Knife Symposium, I mean, this comes up because of the we now have the availability to do this with the new icon units. So what I wanted to start with is to answer the why question too. Why are we interested in hypofractionating or radiosurgery? Because for a lot of things, we do have excellent results with single fraction radiosurgery, and the idea is to try to improve some separation between desired outcomes of tumor control and complications. And so when we switch to fractionated technique, we're going to use a higher dose, but it's split up into additional fractions, but it may have the same biological effect. So when we shift it, we want to see that the space between the tumor control curve and the complication curve has changed in some way. We didn't just shift things in equal distance and then end up with the same separation that we had. So the reason for thinking about hypofractionation comes from studies of radiobiology, and so we'll just touch on the repair of sublethal damage between fractions is why we have to go to a higher total dose when we split up the treatment, instead of giving the exact same dose in 3 parts. And we have redistribution of cells throughout the cell cycle that have different sensitivities. And reoxygenation, as I already mentioned with brain metastases, is a very big issue with fractionation. And then repopulation is one thing we have to watch out for. If we split into multiple fractions and allow tumor cells to repopulate between each treatment, we may end up losing ground. So the repair of sublethal damage mostly occurs in 4 to 6 hours. A lot of it is done. And about half the repair that takes place has a half-life of about 30 minutes. So you get about a quarter repair in about 30 minutes. And the formulas that's been traditionally used to account for effects of sublethal damage repair and infractionation is the linear quadratic model. And that can be thought of, it has a alpha linear component. It can be conceptualized as double-stranded DNA breakage with single kinetics. And you could think of the beta component as single-stranded DNA breakage where you need 2 adjacent hits, and it's a quadratic function. That's the amount of beta damage would be proportional to the dose squared. And we use these formulas to equate different courses of radiotherapy that are fractionated, which would be the total dose plus the dose per fraction divided by the alpha beta, the ratio of the alpha to beta cell killing. And if you're going to have an extended treatment, you need to include a repopulation factor, which particularly kicks in after about 2 or 3 weeks. So if you look at cell cultures and cell killing with dose responses, log survivals, you see these curves with 1 fraction, or this curve with 1 fraction. And if you split up into multiple small doses, you get something like this. And what I was taught as a resident in the early 1980s was that the dogma from radiation biology was that all tumor cells had this low alpha beta ratio, and most of them did in cell culture. And then the normal tissue has this low ratio, and the more you fractionate it and split it up, the more separation you get. But there's several problems with that were very much highlighted by the introduction of radiosurgery, and one that these linear quadratic models overestimated cell killing at very high doses at this range, and so it doesn't really fit. And then the other issue that's not in there is that that's based on cell culture, and treating a tumor is much more complex. You have a whole supporting vasculature that the high-dose single fractions preferentially affects. So a lot of the response is coming from the endothelial cells. So this is the other issue next issue that, and a very big reason for considering fractionating your treatment is reoxygenation of hypoxic cells between the fractions. So I already showed this slide with, which comes from Tomlinson, or this concept from Tomlinson and Gray, that cells are growing that are near the capillary, fully oxygenated, and they're sensitive to the radiation, but as they overpopulate and grow further away, you get a hypoxic zone that's resistant to radiation, but and takes 3 times the dose to kill it. But if you fractionate your treatment, your initial tumor fractions will kill off the oxygenated cells and allow these hypoxic cells to reoxygenate, because originally they were fully oxygenated, living closer in, and then became pushed out. So you may get some reoxygenation like that. And this is just a slide of from a paper on glioblastoma, where they, with 6 weeks of fractionated radiotherapy, outlining the non-enhancing central portion of the tumor, which is invariably hypoxic, and seeing 3 weeks later, halfway through, a lot of that fills in with enhancement. So it should be more sensitive. I mentioned with the brain metastasis talk that we have trouble controlling metastases that are heterogeneous. So they have heterogeneous enhancement, so they don't fully enhance with gadolinium contrast. And they're ones that you might want to consider fractionating your radiosurgery, or the other, or what I mentioned, putting the high central dose in them. So the other reason for considering it is redistribution of cells throughout the different parts of the cell cycle. A lot of cells are, there's a difference in sensitivity. This is log cell survival in different parts of the cell cycle with lowest survival at mitosis. So the thought is that after your first fraction, that the cells that are in resistant phases will move into mitosis, and you'll have a better chance of killing them the second time. And this just mentions that all these models that from traditional radiobiology, from cell cultures, ignore the endothelial response, which is heightened by these high-dose fractions, whether they're single or just limited number of fractionated treatments. And from repopulation, when we're designing a hypofractionated regimen, we want to keep the treatment course under 2 to 3 weeks, so that they can that makes sense. That if you haven't if you haven't killed every last tumor cell and you take a break in the treatment, the cells that are left will continue to grow and divide. And if you wait too long, you may be back at your starting point. So that's from examining different studies, particularly with head and neck cancers, where at one point during the 70s and 80s, it was quite common to give patients a 2 to 3 week break from mucositis, that they could see repopulation or the effects of repopulation on tumor control. So that it seems like that accelerates after 2 or 3 weeks. So if you're going to split up into number of fractions, 3, 5 fractions, you want to get it all done under 2 or 3 weeks. So indications for fractionated radiosurgery are what I feel strongly about using it for is when I have a tumor wrapped around the optic chiasm, and it's difficult to define where the optic chiasm stops and the tumor begins. So for that, regimens such as 20 gray in 5 fractions, or 25 gray in 5 fractions, and 18 gray in 3 fractions are very reasonable to respect optic nerve tolerance and still have enough dose to control benign tumors. And another one to consider is when you have the trigeminal nerve surrounded by tumor and difficult to define, as in a cavernous sinus meningioma or anything filling the cavernous sinus, where you lose sight of where the trigeminal nerve is. That treating with a fractionated regimen may reduce your risk of developing trigeminal neuropathy. And then when moving on to moderately large skull base or cervical spine chondrosarcoma, so there's published experience with treating. We have very good results for small chondrosarcomas and chordomas, manage them with radiosurgery, but as you're getting larger targets beyond 4 centimeters, there's decent published experience with using 5 fractions of radiosurgery, particularly from the CyberKnife literature, 35 to 40 gray for chordoma. I think I made a mistake. That should be chordoma, or chondrosarcoma, 30 to 35 gray, with a 5 to 10 millimeter margin. In spine radiosurgery, we have some evidence that splitting into 3 fractions may lead to better outcomes in some indications, particularly with extensive tumor around the spinal cord. It's used with lung radiosurgery with central targets that we can reduce complications with fractionated stereotactic radiosurgery. And it does seem worth exploring in brain metastases greater than 3 cm, with, particularly I mentioned, with heterogeneous contrast enhancement. So this is a retrospective study for spine metastases, for combining 2 different centers from Georgetown University, where most of the treatments were done with 3 to 5 fractions for their spine radiosurgery, and Pittsburgh, where they were mostly done with single sessions. And there's some problems with that, because the pain assessment from different institutions may be slightly different, and defining tumor control. So it's not a randomized trial, but in terms of their long-term tumor control, when they looked at radiographic tumor control, it was better with the multi-session plans, treatment plans. But just to show that there can be some problems with the study in these retrospective analysis, just looking at pain control, it was reported as higher with a single session treatment. So patients reporting better pain control, but long-term tumor outcome are with single fractions, but the long-term tumor control wasn't as good. It's hard to put those things together. So it still raises some questions of which technique is better. And then looking at the experience with brain metastases, different centers, there's no good randomized trials. This is a group that looked at their experience with brain metastases using 3 fractions with the CyberKnife and calculating a single fraction dose equivalent of 14 gray as a parameter equating things. So they just calculated that using a alpha-beta ratio of 2 for equivalence and in terms of tolerance. And what they report is very good tolerance below 5 and 7 cubic centimeters, but for 14 gray equivalent. But still, that's if they're treating 14 gray to greater than 7 cc's, isn't that high a cutoff in terms of how big the tumor is, and still getting these high rates of radiation injury reactions. So it's not that convincing from that article that the 3 fractions are much safer and much more effective. This is a dose escalation study for large brain metastases, again from a different CyberKnife unit, 25 to 40 millimeters in diameter. And the radiation injury, there's problems with this study because they have a mixture in terms of reporting the results. They have 3 dose levels with 18 to 22 gray in 3 fractions, 22 to 27 in 3, and 27 to 30 in 3. And then they also at the same time have a dose regimen for 5 fractions. So it's just all mixed together and reported in one lump report. So it's hard to make a lot of sense out of it. But if you look at the local tumor control for these large tumors, they are reporting quite high tumor control. So that does look very promising in terms of high levels of tumor control, possibly because of these regions or these reasons that I mentioned why we should consider it with heterogeneity, that perhaps there's problems with the large metastasis of radioresistance from tumor hypoxia. You're catching them in different phases of the cell cycle. And so it's certainly worth exploring with the large brain metastases, the larger brain metastases that treat in multiple fractions. And this is looking at experience with chordomas treated where they recommend 40 gray in 5 fractions, and the results are pretty similar to what we've been seeing with proton beam and gamma knife, but it's quite a high dose and it's very biologically equivalent to what they're pushing with the proton beam. So hypofractionated, our technique, of course, is for terms of precision in the brain and upper cervical spinal cord. Gamma knife icon seems very promising, and we're very happy to be starting with that in the next few months. CyberKnife true beam techniques, 3 to 5 fractions really is define radiosurgery. That's really just the terminology. There's at times I've moved to 6 fractions of high dose IMRT with large fractions, such as with treating a CyberKnife. And that's certainly reasonable. In terms of how to do that, there are a number of papers that give you reason to think about treating every other day and not daily. So one of the very early papers from from LINAC radiosurgery with acoustic neuromas was from a group that used or that looked into treating acoustic tumors with 5 fractions and looked at their rates of hearing preservation with daily treatments and every other day, and found much better hearing preservation when they went to every other day. And in the treatment of recurrent head and neck tumors, particularly with tumors around the carotid artery, the institutions that have been treating every day with daily fractions seem to have much higher risks of developing carotid blowouts. So there does seem to be repair that takes place beyond just that 24 hours with these very high dose. So almost all our hypofractionated treatments have been, in terms of the LINAC platforms, have been with every other day treatment. And we want to treat as I mentioned, we wanted to complete our treatment course in 3 weeks. So what I found with cervical spine chordomas, where if you have to treat particularly the lower or mid-cervical spine, C3 to C5, that you can have a lot of mucositis in those patients, and have been doing 3 fractions the first week and then giving them a week break for mucositis, and it still gets done under 3 weeks. So I did have an interesting fractionated case to show you with the chordomas. And this patient was a clival chordoma that was treated by proton beam radiation, and then about a year later developed spread of tumor just below that into C1 to C3. So we were able to treat that with radiosurgery, and but the patient came in for his I think it's about a 9-month follow-up after the spine radiosurgery, and his wife had mentioned his memory's very poor now, and do you think it was the radiosurgery you just did? And I looked at the scan. This is actually a later follow-up, but there was a little bit more enhancement. So it was more than 2 years and 9 months after the proton beam treatment. We were seeing bilateral temporal enhancement from the proton. And I put the patient on a short course of a 6-day course of corticosteroids combined with starting pentoxyphylline and vitamin E. And so the patient had an immediate improvement in his memory, and I kept him on the pentoxyphylline and vitamin E for 3 months and then stopped it, and he was fine. So we do have to keep watching for radiation injury reactions even beyond 2 years, particularly with the fractionated techniques. So that resolved, and so far we have very good tumor control. So the other issue that shows up in these patients when you're treating around C1, C2, we're giving a relatively low dose to the parotid glands. So you don't really pay attention on it. You might not need to pay attention, or might think that you may not need to pay attention to the parotids because you're not going to give enough dose to cause permanent xerostomia, drying of the mouth. But it doesn't take very much to cause an acute inflammation of the parotid glands. So I've seen a number of these patients at C1, C2 come in, call in a day or two, a day after treatment with pain from inflammation of the parotid glands. So after I saw that, the second time I pre-treated those patients with corticosteroids the day of treatment. And that seems to block that response. So that's a nice thing to think about. A lot of these patients are at risk for developing a flare in their bone pain anyway. So it's always it's a very reasonable thing to do to pre-treat these patients with corticosteroids. But the ones that caught my attention were post-operative patients where they didn't have tumor to swell and stir up pain, so that there was no reason for them to call in with sudden pain in their throat and around there. And so the first patient that called about that made me think that it was a radiation injury reaction inside the throat. When she came in on the Monday morning, I realized it was that it was inflammation of the parotid gland. So that's a nice trick to think about. So I think I'm over my time, so I think we should pause for questions.
Thank you very much, Dr. Flickinger. Tabii radyoterapide fraksiyone tedaviler çok uzun yıllardır zaten yapılmakta ve standart tedaviler arasında düşünülür. Ama özellikle son yıllarda teknolojideki gelişmeler, tümör biyolojisinin daha iyi anlaşılması sayesinde hipofraksiyone tedaviler, yani eskiden diyelim ki işte 30 günde, 1,5 ayda tedavi edilebilecek bazı tümörlere daha kısa zaman aralığında, işte 5 günde, 10 günde gibi daha kısa zaman aralığında radyasyon uygulayarak hem tümörü etkilemek hem de etraftaki sağlıklı dokuya zarar vermeden bu işi yapabilmek mümkün mü? Bunun arayışı içinde hepimiz, bütün dünyada olduğu gibi biz de. O yüzden de mesela bizde de bazı hastalarda diyelim büyük kafa kaidesi, menenjiyomu ya da ne bileyim büyük AVM gibi bazı hastalarda hipofraksiyone tedavileri kullanıyoruz dünyanın pek çok yerinde olduğu gibi. Is there any question for Dr. Flickinger about this subject? Yes, Dr. Meriç Şengöz wants to ask a question to you.
Sure.
Hi, Dr. Flickinger. Do you use hypofractionation for AVMs, large AVMs?
There is some very interesting literature on that, but so far we've not done any fractionation of our AVMs. We've basically, with large AVMs, we moved to staging it where we treat half the AVM and then somewhere 4 to 6 months later treat the other half, 3 to 6 months later treat the other half, and thought that might be a better approach than just fractionated. But there are some reports that look encouraging with the fractionated techniques, so we've not yet done that. And,
okay, and a second question, do you use fractionation number more than 3-5, for example 10 or something, for any kind of...
Certainly we do with conventional radiotherapy, but with a number of times we have problems with, in the United States, we need insurance approval for everything we do, and for some things that a number of the chordomas that are in the spine, they won't approve. I had trouble getting approval for radiosurgery, but they would approve for IMRT. So if I switch to 6 fractions, there's no problem with getting it authorized. So I've done a few things that have been 6 fraction, with techniques that are pretty much radiosurgery, but they don't meet the definition of radiosurgery, so which is just defined arbitrarily as 5 fractions or less. So 6 fraction radiosurgery. So I do remember treating a post-operative treatment for a huge sacral chordoma that way that did extremely well.
Thank you. Is there another question? Yes, there is another question to you, please.
Sure.
I'm Dr. Aziz Hatipoğlu from Department of Neurosurgery, Gamma Knife Unit at Bezmi Alem Vakıf University. Thank you very much for your nice talk. My question is about tactile gliomas. How would you treat tactile gliomas? Do you prefer fractionation? Can you tell us some specific protocols and some doses? Thank you.
Oh, you're talking about low-grade tactile gliomas, I would assume.
Yes,
so
that's right.
most of well, it depends on whether you're talking about if it appears to be a grade 1 pilocytic astrocytoma, then we've seen very good experience with treating that with radiosurgery. I think most of the grade 2 ones have been treated with fractionated radiotherapy, although we have some limited experience with radiosurgery. So mostly in the tectum, we're using, we're trying to keep the dose moderate. So I guess it's all tailored to size. So 15, 16 gray seems reasonable for something 1 centimeters, 10, 15 millimeters in size for a single fraction for a tactile glioma. But it's such a rare tumor, we don't really have a decent series to answer that question. Did you have any feelings about that, Dr. Lunsford?
I mean, I think that some tumors we can use for pilocytics, probably doses of around 12 gray at the margin. Some of the larger tectal tumors we've divided into 2 anatomic stages, treating 12 to 13 gray to the 2 anatomic volumes. In general, we have switched to using radiosurgery for these cases rather than any type of open surgery because they're generally in very bad location with high morbidity risks for brainstem injury. So radiosurgery, I think, has a role for these tumors. Primarily, it's going to be used for pilocytic tumors.
So I don't know how well you heard that, but I was basically advocating mainly for the pilocytic tumors with doses of 12, 13 gray. And I think there's been times where we've done it with a staged approach, but most commonly, if the volume's small enough, that seems a reasonable strategy. And then if it's too large, going beyond 4 centimeters or something like that, it's time to think about conventional fractionated radiotherapy.
Thank you very much. Is there any other? Okay, I think everything is okay, and I would like to thank you and Dr. Lunsford so much for being with us today, and also another message to Dr. Lunsford, the IT gods what with us today, and we are very thankful to them also. So we hope to see you in the near future, and thank you very much, both of you. Bye bye, and see you.
Thank you very much for allowing us to speak.
Yes, thank you. We really enjoyed it. I wish we could be there physically rather than digitally, but that will have to wait till the next time.
Thank you. Şimdi toplantımızın son konuşmasını Doktor Meriç Şengöz yapacak. Kendisi glial tümörlerde gamma knife radyo cerrahisinin kullanımı konusundaki tecrübelerini aktaracak. Buyurun.
Bunu değerli meslektaşlarım, sevgili konuklar, hepinize iyi akşamlar diyorum artık. Oldukça yoğun bir gündü. Sanırım vakti de biraz geçtik ama bu biraz da sevimsiz konuda hiçbir şey söylemeden olmayacak diye düşündük ve programa koyduk. Glial tümörlerde radyo cerrahinin yeri. Ben sizlere önce özellikle radyo cerrahi veya stereotaktik tedaviler hakkındaki bazı temel görüşlerimizi belki tekrar bile olsa biraz kısaca da olsa vurguladıktan sonra glial tümörlerin son yıllarda biraz da değişime uğrayan tanı ve tedavisinden bahsederek bu ikisini nasıl bir araya getirebiliriz? Yani burada radyo cerrahinin bir yeri var mıdır? Anlatmak, izah etmek istiyorum. Sadece stereotaktik radyo cerrahi de değil, stereotaktik fraksiyone radyoterapiden de biraz bahsedeceğim. Sizlerin de fark ettiği gibi bu son yıllarda giderek daha öne çıkan bir konu olduğu için özellikle. Biliyorsunuz ki stereotaktik tedavilerde tek seferde yüksek dozu çok sınırlı bir arana vererek hem etkinlik hem de çevresel dozdaki hızlı düşüşle bir yan etki azlığı sağlamaya çalışıyoruz. Bunu fraksiyone tedavilerde biraz daha arttırmayı bile düşünüyoruz. Özellikle bazı tümör tiplerinde. Burada çoklu fraksiyonasyonla ve sadece intrakraniyal değil ekstrakraniyal hedeflerde de gene sınırlı alana yüksek dozu verirken çevresel dozda hızlı düşüşü sağlamaya çalışıyoruz. Ve bu tip tedavilerin ortak özelliği de bir kere çok iyi bir hedef belirleme. Artık elde ne varsa, intrakraniyal için konuşuyorsak MR'ın bütün sekanslarını ve spektroskopiyi hatta metabolik görüntülemeyi kullanarak en iyi hedef belirleme ve bir şekilde immobilizasyon ve bunun gerekiyorsa görüntü kılavuzluğunda tedavi günlerinin sağlanması ve ona uygun da eğer fraksiyon ediyorsak bir doz toplamını belli bir sayı fraksiyona bölerek vermek. Bunun için cihazlardan da bahsedildi. Hepsi aşağı yukarı birbirine eşdeğer denebilecek sonuçları verebiliyor. Belki kullanım farklılıkları var. Bir de tabii ki gene vurgulamakta fayda var. Olmazsa olmazları var bu tip tedavilerin. Özellikle stereotaktik tedavi yapıyorum diyorsanız mutlaka doğruluk ve hassasiyeti bir şekilde sağlamanız, en iyi sabitleme, görüntüleme ve ardından da hedef çizimi ve ona uygun planlamayı yaparak ve bu tek yüksek doz ile fraksiyonasyonun arasındaki en önemli farkı biraz önce Flickinger'da da belirttiği gibi özellikle radyobiyolojideki bir takım kurallar ve onlara uyumu şeklinde düşünmemiz lazım ve belki biraz da doz heterojenitesi, düşük doz alanlarındaki tepkiler ve bütün bunların hepsi bir arada düşünülmeli. Ve bunları daha ilk radyo cerrahinin ilk yıllarında Larson'un kendine göre dokuların hedef olanlarının geç veya erken cevap verenler olarak ikiye ayrıldığında ve normal dokunun yani çevredeki normal beyin dokusunun hedef içinde kalıp kalmadığına göre ve onun da bir geç cevap veren doku olduğunu düşünürsek bir modellemeyle bir kategorizasyon yapmış idi ve buna her birine birer örnek koyduğunda da aslında erken cevap veren bir tümör tipinin derecesi arttıkça daha da belki artan bir şekilde geç cevap veren bir dokuyla iç içe olmasının temsil edildiği glial tümör grubu aslında belki de diğerlerine göre en olumsuz veyahut da en kullanışsız idi. Ve her ne kadar en iyi planı yapsak bile o da anlatıldı sabah biraz önce. Gene de malign glial tümörde bir takım sıkıntılar var. Şimdi oraya geçeceğim. Glial tümörleri de malign glial tümörler öncelikli olarak anlatacağım ama tabii ki düşük dereceli glial tümörlerden de kısa bahsederek. Burada bizler açısından sadece astrostik ya da oligo özelliği veya bunların mixed olması ya da derecenin yükselmesi gibi bir takım histopatolojik özellikler değil, artık son yıllarda moleküler bir takım belirteçlerinde burada sayıldığı gibi hem bakılabilir olması hem de bunların belli bir gidişata ve ona uygun tedavi seçimine de öncülük etmeleri ya da kılavuzluk etmeleri giderek sanki önümüzdeki yıllarda bildiğimiz standart tedavilerin yani mümkün olduğunca güvenli bir geniş rezeksiyon sonrası radyoterapi ve onunla eş zamanlı son yıllarda yerleşmiş temozolomid tedavisi ya da herhangi bir şekilde bir sistemik tedavi diyelim. Sanki o biraz daha değişecek gibi. Bununla ilgili patoloji gruplarının, nöropatologların özellikle bir araya gelerek sanki önümüzdeki kısa bir süre içinde de belki evrilemeyi ya da derecelendirmeyi de değiştirecek şekilde bir takım bu moleküler belirteçler üzerinde çalışarak farklı derecelendirmelere geçmeleri mümkün. Ve ona uygun hedef belirlendiğinde de tedavilerin de buna göre değişmesi ve o hedeflere göre tedavilerin sistemik olarak verilmesinin belki de bizim lokal tedavilerimizin de önüne geçmesi ihtimali var. Biz yine de radyasyon tedavisinin glial tümörlerde etkin bir tedavi olduğunu bugüne kadarki tecrübelerimizde ve eskiden beri var olan bir takım çalışmalarla biliyoruz. Ve bir doz yanıt ilişkisinin de bir yere kadar olduğunu biliyoruz. Yani bu da test edilmiş ve karşılaştırılarak bir yere gelmişiz. Bir şey daha biliyoruz. Hani nükslerin de özellikle malignite arttıkça belki biraz daha ötelerde, birkaç santim ötede, hatta beynin neredeyse her tarafında olabileceğine dair yayınlar olsa bile çoğunluğunun ilk birkaç santim içinde olduğunu da biliyoruz. Bunlar sanki radyasyonla ilgili hem etkinliği hem de dozu arttıran bir yöntem olarak radyo cerrahinin uygun olduğunu ve etkili olabileceğini gösteren ipuçları, ama bir yandan da gene biliyoruz ki bu tip tümörlerin çoğunda infiltratif bir yapı ve bütün beyin içinde neredeyse ulaşabilme, yani yayılabilme olasılığı. Bu da ek dozun radyo cerrahi ile verilmesinin karşısında bir gerekçe. Bir şey daha biliyoruz. Tabii özellikle hasta seçiminde prognostik faktörleri bir araya koyduğumuzda yaşla birlikte performans skorunun da iyi olduğu, boyutun küçük olduğu ve başka yerlere yayılımı olmayan ve lokalizasyon itibariyle uygun hastalar radyo cerrahiye uygun olarak adlandırılırsa, bunlar da zaten az çok bir havuzun içindeki hastaları radyo cerrahi yapmaksızın değerlendirdiğinizde radyo cerrahi uygun diyebileceğiniz hasta grubu zaten diğerlerine göre biraz daha iyi gidişli. Ama biz bunu biraz daha nasıl arttırabiliriz? Acaba gliom grubunda radyo cerrahinin bir yeri var mı? Yani gerçek sınırları nasıl belli edebiliriz ve ona uygun bir dozu arttırarak bir fayda sağlayabilir miyiz? Eğer bunu tek seferde sağlayamıyorsak acaba fraksiyon ederek bunu gerçekleştirebilir miyiz? Bu boşluğu doldurabilir miyiz? Ya da bütün bu radyasyon tedavilerinden hangisini kullanıyor olursak olalım, bunun yanına bir ilaç ya da herhangi bir sentezizan madde ekleyebilir miyiz? O yüzden de malign gliyomlardaki standart tedavi veya olası senaryoların herhangi birine stereotaktik tedavileri, radyo cerrahi tek sefer ya da fraksiyone stereotaktik radyoterapi olarak koyabilir miyiz? Her zaman bunu erken döneme de koymak pek mümkün değil hasta seçiminin zorluğundan dolayı, ama acaba böylesi çok sınırlı nükslerde bunu kullanabilir miyiz? Yani hem erken dönemde ek doz boost çalışması hem de daha geç dönemde nüks sonrası çalışmalar var mı? Onlara bir göz atalım. Bu konuyla ilgili eski çalışmaların bir araya toplandığı bu slaytta hem grade 3 hem de grade 4 için sınırlı sayıda hastalarla belli bir tedavi sonrası, radyo cerrahi sonrası bir ortalama yaşam süresi elde etmek mümkün. Bu da aslında bazı serilerde hele çok çok iyi gözükmekle birlikte. Buna ait bir prospektif randomize çalışma yapma gereği yapılıp 93 yılında arkeoloji tarafından dizayn edildikten sonra 2004 yılında Kırmızı Dergi'de Suhami ve arkadaşları tarafından yayınlandığında görüldü ki 200 küsur hastalık bu çalışmada standart tedavinin hemen önünde, yani o gün için standart tedavinin hemen önünde verilen ve aslında çok da düşük olmayan ve gene bir takım çalışmalarla belirlenmiş boyuta göre dozlarla hem genel yaşam oranlarında, ortalama yaşam oranlarında hem de lokal kontrol ve yaşam kalitesi oranlarında herhangi bir fark yaratılamadı. Yani bu aslında radyo cerrahi olarak ek doz vermenin işe yaramadığını gösteren bir negatif çalışmaydı. Ve o gün bugündür de benim bildiğim kadarıyla en azından bunun aksine bir çalışma olmadığı gibi başka bir prospektif büyük randomize çalışma da gelmedi. O yüzden de gene o yıllarda aslında epey de zaman oldu. Astro'nun, yani Amerikan radyoterapi grubunun konsensus bildirisinde bütün bu çalışmalar bir araya konulduğunda dendi ki etkinlik ve toksite bir fark yaratmıyor. Datalar sınırlı, sonuçlar çelişkili. Eldeki tek büyük çalışma zaten negatif demiştik. Bunun sadece radyo cerrahi olarak boost ya da kurtarmada nükste kullanımı değil, fraksiyone edildiğinde de gene boost olarak ya da nüksteki kullanımında da sonuçların çok iyi olmadı. Ama yine de bütün, birazdan da göreceğiz birkaç çalışma, bütün çalışmaların en son cümlelerinde hep iyi tolere edilebildiği, herhangi bir ciddi sıkıntı ve toksite yaşanmadığı, o yüzden de biraz daha irdelenmesi gerektiğiyle biten çalışmalar. Bu da bir faz 2 çalışma. Gene biraz farklı bir yere yerleştirilmiş, yani tedavinin arasına serpiştirilmiş bir fraksiyone ek doz çalışması, ancak onda da gene ciddi bir fark yaratılmadığı gibi hep bildiğimiz yaşam sürelerine ulaşıldı bu yüksek dereceli glial tümör çalışmaları. Gene o yıllarda yayınlanmış bir Alman çalışmasında da nükste, yani nüksettikten sonraki GBM'lerde stereotaktik radyo cerrahiyle ne gibi bir ek fayda gösterilebileceğine dair çalışma. O da aşağı yukarı 10 ay civarında bir ek ortalama yaşam süresi sağlandı. Fraksiyonel çalışmalarda da gene hem Alman grubun hem de onu izleyen bir takım başka çalışmalarda, mesela İtalyan çalışması Miniti'nin yaptığı ardı ardına birkaç çalışma göstereceğim. Onlarda da gene fraksiyonel stereotaktik re-irradiation, yani ışınlanmış alanda tekrar nükse yönelik ışınlamalar. Farklı dozlarla da olsa, farklı toplam dozlar ya da fraksiyonasyonlarla da olsa ve birbirinden farklı ilaçları ve biraz da farklı sekanslarla, yani eş zamanlı ya da düşük doz şeklinde ya da bevacizumab ya da fotemustin gibi ilaçlarla birlikte kullanılsa da gene 10-12 ay civarında bir ek yaşam oranı sağlayabildiği gösterildi. Ve de bununla ilgili gene bir Amerikan Ardiyoloji ve Enerji Onkoloji çalışması yürüyor. Bildiğim kadarıyla henüz yayınlanmadı. Onda da gene sadece tek başına bir bevacizumab kullanımına radyo cerrahi veyahut da re-irradiation'ın bir şekilde tam da biraz önce Flickinger'da söylediği gibi radyo cerrahi denemeyecek şekilde, yani 10 fraksiyonda verilmesinin test edilme çalışması var. Bekliyoruz. Belki oradan bir katkı gelebilir. Özetle uzun yılların bilgi birikimi ve yeni ilaçlar, yeni teknolojinin kullanımıyla hem radyo cerrahi tek doz hem de fraksiyone stereotaktik radyoterapilerle ve dağınık hasta gruplarıyla, küçük çalışmalarla bir ilerleme pek kaydetmiş sayamıyoruz kendimizi. Gene de kullanmıyor muyuz? Kendi serimizde de çok da azımsanmayacak sayıda hasta var. Şöyle bir göz attığımız zaman onların da çok uygun lokalizasyon, daha doğrusu lokalizasyon belki uygun değil. Bu hasta sadece biyopsiyle bize gelmişti. Ama uygun boyutta bir hastada standart radyoterapiye eklenen bir ek dozun da belki katkısıyla oldukça uzun bir kontrol sağlanabildiği ya da gene bu hastada olduğu gibi bu ardı ardına hem 2007'deki ameliyat sonrası, yani postoperatif kemoradyoterapinin standart uygulamasının üstüne nüksettiği için 2 kez gamma knife çeşitli zamanlarda ve daha sonra buna rağmen biraz farklı lokalizasyonlarda nüksettikten sonra da gene 2 kez daha fraksiyonel radyoterapi almış bir hasta. Yani oldukça uzun bir süre yaşamış ve birkaç kez ve birkaç merkezde histolojisi de yani konfirme edilmiş bir GBM hastasıydı. Böyle bir ekstrem vakada tabii hepimizin karşısına zaman zaman gelebilir. Tek tük vakalara bakarak değil ama çalışmalara bakarak bir yol alamadığımızı görüyoruz. Fakat bazı seçilmiş vakalarda da bunda da olduğu gibi uzun bir süre sonra nüksetmiş hastada gamma knife sonrası yine uzun bir süre kontrol sağlayabildiğimizi gösteriyor. Aynı şey anaplastik grup için de geçerli, grade 3'ler için de geçerli. Gene gördüğünüz gibi gamma knife sonrası önce bir erken dönemde bir takım sıkıntılar olsa bile, bir nekroz görüntüsü olsa bile daha sonra tamamen iyileştiği görülebiliyor. Gene bir epandimom, anaplastik epandimom vakası. Aradan uzun bir süre geçtiği halde güzel bir kontrol sağlanabilmiş. Genel olarak bütün bunları bir araya topladığımızda diyebileceğimiz bir sonuç slaytı şu. Oldukça sınırlı bir ve küçük bir hasta grubu için belki radyo cerrahi uygun. Bunlarda bir ek katkı sağlayabilir. Ama en azından bir toksite getirmediğine dair birçok yayın sonunu bu şekilde bağlamış cümlesinin. Düşük derecelilere geçtiğimizde de bunları da hızla geçelim üstünden. Grade 1-2 gliomalarla ilgili gene hem plastik astrostoma hem de Grade 2 astrostoma grubuyla yapılmış birkaç çalışmayı bir araya topladığımızda da yine aslında bu düşük dereceli grupta az çok beklendiği kadar bir veya belki onu biraz aşan bir kurtarma etkinliğine varabildiğini gösteriyor çalışmacılar. Ancak bu grupta da gene hiçbir prospektif randomize çalışma yok. Birkaç örnek. Yine bir biyopsi sonrası plastik astrostoma tanısı alan bir hastadaki gamma knife sonrası erken dönemde biraz şişme, kistik görünüm ama daha sonra oldukça iyi bir cevap. Gene endoskopik bir biyopsi sonrası yapılan gamma knife ve ardından gelen geç dönem takibinde tümörün iyi kontrol edilebildiği. Bir başka hastanın da cerrahiden sonra nüksettikten ve bu haliyle gamma knife yapıldıktan sonraki geç dönem takibi. En azından kontrol altında progresi olmadan durduğu. Bir başka örnekte Grade 2 astrostomda, bu da belki şanslı bir vaka diyebiliriz. Pek uyguladığımız bir şey değil ama sınırlı bir alana gamma knife sonrası bir gerileme sağlanabildiğinin görüntüsü. Sonuç olarak bu grupta radyo cerrahinin veya fraksiyonel radyoterapinin yeri oldukça sınırlı. Bu çalışmasında bir başarı gösteremeyen iyi bir çalışmanın dışında da küçük çalışmalarda zaten fazla bir yol almamız mümkün değil. Belki nüks ya da progresyondaki seçilmiş olgularda bir yeri olabilir ve bunu iyi irdelemek gerekir. Birlikte kullanılabilecek bir takım yeni ilaçların da umut verdiğini söyleyebiliriz. Demek ki hasta seçimi önemli. Onun yüzünden biraz kişisel karar vermek gerekiyor. Hepinize teşekkür ederim sabrınız için.
Teşekkür ederiz Meriç Bey. Meriç Bey'in bu konuşmasıyla ilgili soru ya da katkısı olan arkadaşımız var mı? Buyurun, bir soru var.
Doktor Erkan Şanlıurfa. Hocam daha önceki konuşmalarımızda yurt dışında yapılan istatistikler çalışmalarda malin tümörlerde uygulama oranı daha fazla görünüyordu. Gamma knife'ın. Şimdi malin derken işte glial tümör ve metastazlar.
O istatistiklerin içindeki malinlerin büyük çoğunluğu metastazlar oluşturuyor. Yani glial tümör grubu biraz daha ince bir şerit şeklindeydi ama ayrımı yoktu herhalde değil mi? Hatırlamıyorum.
Yok, ayrım yok. Oradaki hastaların belki %98'i metastazlar. O malin tümör dilimindekilerin %98'i belki metastaz. İşte %1, 2, 3'ü falan glial tümör.
Tamam, peki.
Başka var mı sorusu olan arkadaşımız? Peki, teşekkür ederiz Meriç Bey.
Ben teşekkür ederim.
Sevgili hocalarım, değerli meslektaşlarım, sevgili öğrenciler, hepinize bu sempozyuma katıldığınız, onur verdiğiniz için çok teşekkür ederim. İnşallah 3. sempozyumda tekrar bir araya gelmek üzere. Hepinize iyi akşamlar diliyorum. Tekrar teşekkürler.